This is Lori Manella. I'm re-recording chapter 44 and 45 on eye, ear, and that flows into dermatological medications. As we are progressing through pharm, you've been seeing a lot of repeat drugs given for different disorders and different systems. And eye and ear continue this thought process, and you're going to see many antibiotic drops that are used um, for the eyes and for the ears that are used orally as well. Also, we're going to look at, as far as eyes, from steroidal drops that are used for inflammation, such as conjunctivitis for the eye. Um, and also you'll even see some propionic acid derivatives. You remember the profin suffix. So look for those suffixes and all those meds that you know so far at this point. Many of them are going to be continued here. There are also some allergies and decongestants being given in ophthalmic drops. Lubricants for the eyes, such as artificial tears for eye comfort, and as we age, our eyes get drier, and as many of us have worn contacts for a period of time, we have that enhanced dryness. So it is important for eyes to stay moist for their health. There's also some neurological conditions that decrease blinking. So here we go. We're going to start on eye, and in every one of these systems, make sure you review as well what is normal for that organ or that system. So the eye, the anatomy of the eye, make sure you look over the anatomy of the eye, but we know that our eyes in a gross anatomy portion or the big picture are protected within the orbits of the skull. Eyes are controlled by the third, fourth, and sixth cranial nerves, so anything neurological could possibly, or different neurological disorders could affect our eye movement and sight and so on. So most of the conditions we're going to talk about related to eyes as far as the pharmacological needs and such are due to injury, infections. Non-infective disorders include things like glaucoma, macro, degeneration, and so they're kind of newer. And in MedSurg 1, they do review eye and ear disorders. In MedSurg 2, we will go through skin disorders, and skin is following the chapter 44 on ear and eye. Starting off here, while we don't have a lot to do with diagnostic stains, we can educate patients related to some of these meds and what to expect, and also safety when patients are having eyes anesthetized or stained. They stain eyes sometimes, and you can see a couple examples of what they use. I'm not going to ask you to recall these, but it's interesting. And they have different colors and different things will be stained in the eye, such as foreign bodies or if there's lesions, to bring the attention of the ophthalmologist or optometrist to this area of damage. They can also help when they are stained, the eyes, to evaluate dry eyes or any of those extraocular changes. Along with the stains, sometimes the topical and the stains are given together for that more thorough examination. The anesthetics, they help, as said on your PowerPoint, with a more comprehensive eye exam. They help also with ophthalmic procedures that are being completed. Action, they block pain signals. And you can see this familiar suffix "cane" when we talked about lidocaine and novocaine earlier in the semester. So we have two examples here of some local anesthetic or topical anesthetics for the eye. Corneal anesthesia is achieved within about 1 minute after these meds are given and generally last about 15 minutes. Anti-infectives, these are used for eye infections, and some of the different types of eye infections seen here. We're most familiar with conjunctivitis. Conjunctivitis is an infection of the sclera and the surrounding areas, the membrane. And this is the membrane really covering the eyeball. and also the inner eyelids are considered the conjunctiva. Bacteria, virus, allergies, fungus can all affect the eye. Bacteria are really the only eye infection that are properly treated with antibiotic ointments. There may be an antiviral that can be given, and for allergy we use sometimes decongestant drops. And with the different discharges, it's interesting, and I'm sure you have talked about it or will talk about it in MedSurg 1, that depending on the discharge, really truly bacterial conjunctivitis has a copious amount of discharge that you just can't keep up with it running. Allergy discharge looks more mucoid, kind of mucus that's coming out of the eye. Viral will have discharge, but not as copious as bacteria. We know viral and bacteria are highly contagious, though, and so depending on with children sometimes auto-inject themselves when they have a cold by rubbing their eyes after they've rubbed their nose and things like that. But generally, conjunctivitis for all of us would follow an upper respiratory infection. And so school-age kids, many of them cannot return to school until treatment is started. So when we talk about the eyes, we want to talk about a lot of good hand washing. Blepharitis, this is infection of the margins of the eyelids. Chalcyon are infection of the glands of the eyelids. Endophthalmitis or mitis is inner eye infection. Hortolum is an infection of the eyelash follicles and glands of the eyelids. Infectious keratosis or keratitis is a corneal infection. This is much more serious than some of the others, and inflammation. Infectious uveitis is infection of the vascular portions of the eye. Some of the medications we give for the eyes, the anti-inflammatory, you can see some of the categories here as well as some examples. Corticosteroids, cyclosporin, ophthalmic non-steroidal anti-inflammatory drugs, such as you see ketorolac, and you see that lac is similar in both of these, but ketorolac, that is a med we frequently see given as an NSAID today. Corticosteroids, we might see dexamethasone or prednisolone, and we recognize those suffixes. Anti-allergy meds, we see antihistamines. They could be either of the antacids, antihistamines that we use second or first generation. You might see Benadryl, Zyrtec as a second, or so on, and mast cell stabilizers. Decongestants, ophthalmic decongestants. The action here is to stimulate the alpha adrenergic receptors in the arterioles of the conjunctiva, narrowing blood vessels and decreasing congestion, may have systemic absorption. One of the things we want to be careful of when we're giving eye drops is that, especially prescription eye drops, is that when we give them, first of all, it should only be 1 or 2 drops in each eye. The pocket, one is even better. The pocket, when you pull the eyelid back, really is a very small area, and really the max that it can absorb is about 2 drops. But one of the ways we prevent or try to prevent systemic absorption and have the drop absorb entirely into the eye is we put the drop into the pouch when we pull that eyelid back from the lower lid. We put it in, and then we place pressure for about 1 to 2 minutes in the inner eye, and that encourages the drop to be absorbed by the eye and not go into the systemic system. Contraindications for decongestants. A contraindication is angle closure glaucoma. Lubricants. Lubricants are often used, and there are many over-the-counter. Lubricants are used for dry eyes, and as we age, our eyes become drier. those of us who wear contacts over time, our eyes become much drier. Anybody who's had um, an eyelid surgery, a cosmetic surgery, will find that they have drier eyes. So these lubricate our eyes, and we know for health our eyes should stay moist. An example would be Tears Natural, like I have up one here. Glaucoma and ocular hypertensive medications. There are a couple types of glaucoma. These include open and closed. Open, the trabecular meshwork structure is open in the eye but becomes clogged. Interocular pressure then gradually increases, and this can damage the optic nerve. In the closed angle, the iris is situated close to the drainage angle, and this blocks the trabecular network, and excessive aqueous humor cannot be drained, and the pressure, interocular pressure, develops when the drainage is completely blocked. So this is a more serious glaucoma, and this can be primary, secondary. Treatment of glaucoma, there are several different types of medications or categories here. We recognize some of these categories. Some are brand new, like the prostaglandin analogs, as far as not brand new to the pharmaceutical industry, but to us studying pharmacology. Beta-adrenergic blockers, we have studied beta-adrenergic blockers before, and alpha-adrenergic blockers. So you're going to see some familiar suffixes when we review these meds. As do cholinergic agents. We've studied what those drugs do. Carbonic anhydrase inhibitors, this is a new category for us. And systemic hyperosmotic drugs. This is new. So we're going to review some of these. You do not have to memorize all of these. I want you to think of glaucoma meds, something like Tinoptic, which will be on our test prep of the medications for exam 4. It is very important for our glaucoma meds so that we do, as other eye meds, but especially these, when we put them in, we put the drops in the lower pocket of the eyelid, that we do that pressure in the inner eye. All right, so going down these each, and we'll give some examples. The prostaglandin analogs, they're used in open angle glaucoma and ocular hypertension, and they improve the outflow. Examples, bimatoprost, and you'll see the prost in the end of these drugs. Ionoprost, taflanoprost, and trivoprost. So when you hear that prost, we're thinking about some different medications that are used for open angle glaucoma. And one of the things that these drugs can do is they can change the iris color. So this, the iris color, not Irish, the iris, excuse me, and darken the eyelids. So this is very different. They can cause macular edema and itching, blurred vision, and redness of the conjunctiva. Another category, and the beta-adrenergic blockers we're aware of, and we see the ending if you look down on the examples, the OLOL, which is the same suffix for the beta-adrenergic oral meds that we give, and this is used for open angle glaucoma and ocular hypertension again, and it does reduce, or the action is to reduce, the IOP. So you see these examples. Side effects: eye discomfort, miosis, bronchoconstriction, bradycardia, AV heart block, and heart failure. Alpha-adrenergic blockers. We see these medications have, in fact, this first medication on the example, apraclonidine. We're aware of clonidine, so we see this DINE in the end, and these are alphagon I have seen pretty familiar. Lopididine I have seen as an antihypertensive PO med given, but not as an eye drop. But these are to help again with interocular pressure. Side effects: burning, stinging, blurred vision, headache, corneal erosion, keratitis, inflammation of the cornea, dysrhythmias, and asthma. So we want to be careful of this and think about the drugs and think about how you are applying eye drops. You want to make sure, and when you're teaching someone, you may have to teach them the steps. So understand those steps in eye drops, and as we go along, how to put eardrops in as well. Another category, carbonic anhydrase inhibitors, and these are for open angle glaucoma. And you see some of the examples, and you see they have a familiar, well, within themselves, these drugs are not familiar to us, but within the category, we see a similar suffix, and that's zolamide in there. So when you see that, try to identify that's what they're for. But as I said, in these eye meds, I'm not going to be asking you to regurgitate all these different categories, but focus on the test prep, and I have, I believe, Synoptic on there for you guys as one of the glaucoma meds. Side effects, lethargy, drowsiness, headaches, seizures, paresthesias, and so on. They are in front of you right now. Okay, with glaucoma and our assessment, so a baseline visual acuity test will be given. Nurses, it could be possible to work in an eye doctor's office. Many times they have certified techs that they teach on how to do it. It's very specialized in there. If you work in surgery, you might be teaching patients how to put eye drops in, or signs and symptoms of glaucoma, or patients in general in the hospital in for other reasons. So we want a baseline, and it's important baselines for patients, period, when they enter into a facility. But this is for visual acuity and intraocular pressure measurements. Also assess for contraindications for glaucoma drugs. And here's some examples of nursing diagnoses and planning. We want them to be able to show us they can care for themselves by administering their drops. And our goal is to keep that pressure within normal or within a target range. Other nursing interventions: monitor for patient status change, monitor for dry eyes, dry mouth, dehydration, fluid overload, all these things, electrolyte imbalances. You can read this. Advise them not to stop this medication suddenly. They will have rebound pressure problems. You can teach them about what drugs to avoid, which will increase IOP. Teach them about giving their eye drops by not touching the tip of their eye, of the eye drop, or to the eye finger, or anything else. But first of all, washing hands and storing the eye drops as necessary. Mydriatics and cycloplegic drops. These are a different category of drugs for the eyes. And these medications dilate the pupils, the mydriatics. The cycloplegics, these paralyze the accommodation muscles. They are used, and both can be used for diagnostic procedures or ophthalmic surgery. Some of the side effects: dry eyes, mouth, photophobia, blurred vision. They might have aches and pains, constipation, increased IOP, seizures, and so on. Drugs for macular degeneration. Now, while we may have not worked with anybody who has this problem, we know this can destroy the vision over years or rapidly. And there's two different types, wet and dry, and you can see the description on here. We understand, and we see the MAB. We've seen this suffix before, and it's monoclonal antibody meds. These meds have been given, or we talked about them being given for arthritis, in chemotherapy, and things like that. So they are the monoclonal antibodies, the MAB, in the end of these meds. Administration of eye drops, and I've kind of been over and over again telling you about this, but check it out. And you have in the bottom some ideas for the steps, but I want you to review them. I believe they're in maybe chapter 13, but they are in your book as well. So review those. For preparation, a lot of the meds have to be shooken, hand washing, pulling down the lid, making that pocket for the medicine. Usually 1 drop per eye, but up to 2 drops. We know the eye and the area absorbs very minimal liquid. And then we have to press on the inner eye corner to encourage the drops to be absorbed by the eye and not flushed out to the system, to the body. Now onto the ear. Review that anatomy of the ear. Check it out. And the more you get to assess patients, and speaking about the ear right now, the ear can be kind of daunting to see, but you want to check it out, look at ears, look at folks, if you work with a physician or a group, look at and compare and contrast folks who have infections and the normal ear. What's the normal eardrum look like, and so on. Drugs for ear disorders, many of them are anti-infective, as well as there are some meds that are given to decrease itching and such. But the anti-infective usually used for acute otitis media and otitis externa acute. Acute otitis media, generally amoxicillin is the drug of choice. If they're allergic to penicillin, they might give azithromycin. Otitis externa, they might use neomycin, polymaxin. We've studied this about the neurological side effects that can happen. Hydrocortisone, chlorphenicol, fluoroquinolones such as Ciprodex. So when we see that, it sounds like Cipro, but it is like ciprofloxacin, which is the suffix for fluoroquinolone. Side effects: burning, stinging, superinfection. Aminoglycosides could cause ototoxicity. Chlorophenicol, we might see a bone marrow depression. Topical anti-infectives for ear conditions. We want to make sure to look at the assessment, record their ear exams for future comparison. We may be checking an audiometry to see their hearing and perform other tests as indicated. And here's the nursing diagnosis or two that are good examples, one being pain related to infection. And the planning will be that they will be free of ear infection after completion of the drug regime. Other nursing interventions, there may be cultures ordered, relief of pain, watch for development of superinfections whenever there's antibiotics given, instruct them to complete all the medication per doctor's order or nurse practitioner's order. Instruct them also to wear a medical alert bracelet if they're allergic to any medications. And this is good for all these patients. Antihistamines and decongestants that can be given. Sometimes what happens as an ear infection develops, first of all, from an upper respiratory, it's all connected in there, or eustachian tube dysfunction. That's when our ears get clogged and we feel it. We might try to chew gum to open it up and such. It feels like you're talking to yourself. But some of the meds that can be given are antihistamines, kind of to open that all up. And remember those side effects with revving up the pulse and so on. Antihistamine, diphenhydramine, one, which is our first group of medications that came out for antihistamine. And then in two, like that could be Zyrtec or something like this. Decongestant examples, POs that might help as well, keep everything going. Pseudoephedrine, phenylephrine, and we see that Ren in the end, and we have studied these medications before. Cerumolytics, this is different, and this is just for ears. The ears develop a lot of wax. This wax is actually antibacterial. It helps also to keep our canals moist and not break down. But many folks clean the ears so much is they end up pushing wax back in there, or the skin in our ears crack, and this can bring on an ear infection, an externa ear infection. Cerumolytics, these are topical otic agents that soften or break up the cerumen. One that we've mentioned is on our list as well, carbonamide peroxide, and this is Debrox. Using oil and peroxide to loosen is sometimes also used as a home remedy. Water-based products provide hydration to dried cerumen, allowing it to disintegrate, and oil-based products that can lubricate and soften wax. Review in chapter 13, I believe, or make sure you look in your book on administration of eardrops. Think about how we're positioning the helix. If it's a child 2 years or younger, we're going to be pulling down and back to get the ear drop in. If it's over 2 approximately, we're going to pull up and back, and that's just straightening that ear and canal to get the eardrops in. And of course, we're going to turn and flex the neck towards the side we're giving the drop in to facilitate that administration. So we're starting on practice question 1. The nurse is teaching a patient with glaucoma. Herbs are important today, and many patients take them, but we asked them what they're taking. They don't state the herb because they really feel it's not a medication, when many medications we've gotten from herbal administration. Which herbal products should the nurse include as not recommended for patients with glaucoma? Garlic, St. John's wort, golden seal, or valerian? This particular deal is valerian, or excuse me, is golden seal. Bitter orange, bloodroot, ephedra, golden seal, and Jiminseed weed. Those others should be avoided in patients with glaucoma. But for patients with, let's see, yeah, with the glaucoma, there are several. That bitter orange, bloodroot, and so on. And you have that list down below this PowerPoint. Practice question 2. The nurse is showing the parent of a 2-year-old child how to administer ear drops, which are correct. Well, with a child that's 2 or under, we're going to pull down the auricle and back. Okay, so A is one of the answers here. Pulling up is going to be those who are older and adults. 3 or C, position child's head with effective ear up. Yep, we can't get it in if we have the affected ear down, so A and C. D is false. E, we would not want to warm the eye drops in the microwave. We could burn the ear canal. We don't want to use any temperatures that are to the extreme, like too cold or too hot. Patient could get dizzy or ear canal could get damaged. Practice question 3. Pilocarpine, and this is a glaucoma medication, has which action on the eye? Meiosis, contraction, allows the eye to drain further. We know with glaucoma there's intracranial or interocular pressure that has built up. B, mydriosis, this is dilation, so the exact opposite of A, so we know this is false. C, ciliary muscle paralysis. D, pupillary dilation. So the correct answer here is A, meiosis. Practice question 4. Which is the most common side effect or adverse reaction associated with prostaglandin analogs for the treatment of glaucoma? C is that very different side effect, that change color of the iris is the correct answer here. That's associated with prostaglandin analogs. Practice question 5. A child is treated 4 times during the summer for external ear infections or swimmer's ear. The nurse teaches the patient's family to prevent these infections by D, using custom-fitted earplugs. So we're done eye and ear. Make sure you review those medications are given. Many are given that are in categories we've learned already. There are many antibiotics there. And then look at some of the different ones, like for glaucoma, macro degeneration, things like that, and ear, the shroomolytics. In chapter 45, this is the dermatological disorders. Basically, this chapter is focusing on some of the bigger ones, and we will bring up skin and dermatological factors in greater detail in MedSurg 2. So this chapter mainly is going to focus on drugs to treat certain skin conditions such as acne, psoriasis, R2, and burns. And burns are studied in MedSurg 3 because they're a more acute and very specialized area. When we think of dermatological pharmacology, we are thinking more of creams, ointments, gels, lotions, solutions that are given. And a lot of these are given for infection or viral, fungal, or bacterial infections as well. So, causes of skin lesions. We have acne is causes skin lesions, psoriasis, eczema, contact dermatitis, drug-induced dermatitis, burn infections, viral, such as herpes, fungal infection. And this is such as athlete's foot, tinea pedis, may be causing lesions. Types of lesions, macules. These are wart-like areas. Are macules actually not so much wart-like? They're flatter. They're like freckles. Papules are actually they raise above. Papules, vesicles. Vesicles are clear pimple-like areas, like in herpes. Um, Plaques are groups of skin lesions. Treatments, topical creams, ointments, paste, gels, lotions, and solutions. For acne, we know these are papules and nodules and cysts from keratin plugs at the base of our oil glands near the hair follicles. Non-pharmacological approach, good cleansing. We usually start at a low percentage of benzoyl peroxide, avoiding abrasive cleaners and over scrubbing. Hair shampooing, water-based cosmetics, well-balanced diet, decrease emotional stress. Pharmacological approach, topical drugs treat acne and prevent new disorders or eruptions. Mild acne would be treated with benzoyl peroxide. Now, benzoyl peroxide comes in 2.5% to 10%. Over-the-counter method for these drugs is not going to come up for those to the higher end, or 10% benzoyl peroxide. We know this medication is very drying and can cause really skin to look worse for a period of time, but it takes about a week for the person to get ready or for the body to acclimate so that it can work on the acne. Moderate to severe acne, treatment with benzoyl peroxide might be at a higher percentage, and topical antibiotics. Retinols, salicylic acid, antibiotics, combinations with gentle cleansing. As we're talking about these medications, the retinols are kind of a second step, but as we're getting moderate to severe, we might also see antibiotics such as tetracycline being given. Review that. Remember, they tend to be very photosensitive, can get a bad burn if they're on tetracycline. They should not, women who are pregnant should not be taking in tetracycline, because this is when the teeth are built up and the calcium will be seeped out. Watch photosensitivity. They should have sunscreen on. The action of some of these meds, topical antibiotics accumulate in the hair follicle and they exert anti-inflammatory and antibacterial effects. Systematic anti-acne drugs, isotropinoin. This is Accutane. This is a very strong medication. It takes about 4 to 6 months to work. It at first will create a lot of redness of the skin, so you have to talk to the patient about that. Before patients can go on this, they must make the pledge that they will stay on. They will have a birth control method and they will back up that method. It is only used for severe cystic acne that's unresponsive to conventional therapy. Side effects: skin irritation, pruritus, temporary hair thinning. Monitor the liver, and the iPledge risk management program is, patients must sign this before they go on it, but they must agree and pledge they will stay on their contraceptives and in fact have a backup many times. Because this medication, Accutane, can cause, or isotropinoin, can cause birth defects. Psoriasis. Psoriasis, another term we probably heard of many times and know folks with psoriasis. They have scaly, very red plaque or scales. Um, they tend to use a topical corticosteroid treatment, usually a course for 4 weeks. Side effects of corticosteroid treatment is skin atrophy, striae or um, skin changes, um, acne, folliculitis, purpura, worsening of existing condition, fungal infection can all happen. Some systemic drug treatment. Methotrexate, we have heard of this before. It is given in chemo. It's given for arthritis. It's given PO. It's a PO drug. Cyclosporin, acetyltrentin, and biological response modifiers can be given. Methotrexate side effects: dermatitis is big, GI distress, fatigue, teratogenetic effects, myelosuppression, hepatotoxicity, and pulmonary fibrosis. We know we cannot take, we should take this drug with some food that it can cause great distress, and we should monitor the CBC. Cyclosporin side effects: hypotrichinosis, fatigue, hypotension, nephrotoxicity, cephalgia, myalgia, arthralgia, so many aches and pains, and paresthesias. Assessing patient with acne and psoriasis. Assess their skin eruptions. Obtain cultures. Obtain a baseline lab value. Skin integrity, risk for disturbed body image are a couple of appropriate diagnoses. Planning, we want the patient to have an improved body image, and they'll verbalize it, and they know that they must use 2 methods of contraception if they're using Accutane. Other interventions: the topical medication will be applied to skin lesions using a aseptic technique. Lots of good hand washing. Monitor vitals. During drug therapy, check lesion sites for improvement. Is the drug working? Listen to the patient's body image concerns and provide community resources if applicable. Advise the patient not to use harsh cleaners. Verruca vulgans, this is a typical wart. Hard, horny nodule may be benign or precursor to a cancer lesion. Can be contagious. It's usually removed by cold therapy or cryotherapy, electrodesiccation. They use a probe to really break it down and to take it away. Surgical excision, they can cut it off. Chemical peels, they can use salicylic acid, which is an aspirin type peel, tretinoin, glycolic acid, anti-cancer drugs, and immunotherapy. Drug-induced dermatitis, the biggest thing I think of when I say this is something like a penicillin being given and having to get Benadryl at home. But drug-induced would be from penicillin, so we're going to be very careful with that. These folks would have a rash, and sometimes it comes up so quickly. Urticaria, papules, and vesicles. We want to be very careful and we watch for drug hypersensitivity. Contact derm, it's a form of eczema where the skin is exposed to irritants or allergen. They get a rash, they're very itchy, swelling, burning, stinging. Non-pharmacological measurements might be comfort, use a cool fan. Pharmacological measurements, they might use boro solution, zinc oxide, oral antihistamines, topical anesthetics, and corticosteroids. Impetigo usually comes about a lot more in the winter, usually with children who are picking at their lips because they've broken down there, or a person who has had an upper respiratory, and a child or an adult, and they have rubbed their nose and then somehow have rubbed their lip as well. But this skin infection is caused by strep or staph. Younger population usually. Pharmacological treatment, topical for mild to moderate, and oral systemic drugs for severe. And we use Bactroban for impetigo. Hair loss and baldness. Etiology might be due to family and aging, a genetic impairment, pregnancy, my eczema, cancer therapies, treatment, minoxidil. This came out for blood pressure first. You got to be real open to these patients as well. This is difficult with body image. Finasteride, this is used for benign prostatic hypertrophy as well, but it is one of the side effects is hair regrowth. It is usually seen after being on it for 3 months of treatment. Sunscreen, very important to protect the skin. It is our largest organ. It blocks those UV rays. It helps us prevent skin cancer, premature aging, cold sores, and fever blisters. Many folks with very delicate mucosa will develop these blisters. Sunscreen types: chemical, absorb UV radiation, and physical, effective for UVA and UVB radiation. SPF is our sun protective factor, and we know today we should be using 50 or greater, and preventative measures. Burns you're going to go over in a great extent in Med-Surg 3. Types of burns: thermal, electrical, and chemical. Up here, even though books 2018, they have classification as first, second, and third. We really don't use those anymore. We use primary, secondary, and so on, different stages of burns. Complications of them: dehydration with hypovolemic shock, infection, sepsis. One of the most important things for somebody who's burnt, of course, is watching the airway first. Is that intact? Is there any sign or symptom that the patient has been burnt in their lungs? How are we look and see if there's any soot around the nostrils, in the mouth, and so on. This would be a big clue. After we take care of the airway, if they're breathing well, we're going to think of hydration right away. They use hydration resuscitation right away, and they're given thousands of cc's. They use a formula called Parkland formula, which is going to come up in Med-Surg 2 for you to know, so we can document how much fluid a patient should be given in that example in the 8 hours. Treatment: keep burn area clean, debride necrotic tissue, broad spectrum topical antibiotics if patient has a large burn area. Burn preps: Silvadene or silver sulfadazine. Its action is against both the gram-positive and the negative organisms. Side effects with Silvadene: photosensitivity, skin discoloration, burning rash, skin necrosis, leukopenia. We want to assess patient and look for signs and symptoms of infection in the burn tissue. Culture anything that looks infected. Determine their fluid status. Nursing diagnosis: imbalanced fluid volume, risk for infection, risk for pain, acute. Planning: the patient's pain will be decreased or tolerable. The patient will remain hydrated. Nursing interventions: continue administering pain med, especially before you scrub or change dressings or before they walk, things like that. Apply topical antibacterial drugs and dressings as ordered. Maintain patient's fluid balance and renal function. Monitor patient for side effects of topical drugs, and monitor their vital signs and be alert for signs of infection or hypovolemic shock. Practice question 1. Finasteride is used to treat male pattern baldness. The nurse knows that in higher doses, the drug is used to treat which? It is A, BPH, or benign prostatic hypertrophy. Question 2. A patient is ordered to receive isotretinoin for acne vulgaris. What is considered priority information in teaching this patient? We know this is a teratogenetic medication if the woman would get pregnant birth defects could be caused. So our number one concern here is C, contraception or abstinence from sexual intercourse. 3, patients admitted to the emergency department with a burn that consists of pearly white skin with areas that are charred. The patient is not in pain. The nurse documents the burn as D, full thickness. Superficial epidermal burns are red and painful. Partial superficial burns are blistering and very painful, and deep thickness burns are mottled and blistering with intense pain. In practice question 4, we talk about a patient receiving extensive amounts of mefenide acetate for the treatment of burns, and they're at most risk for the development of which imbalance? And this is B, metabolic acidosis. Practice question 5, and this is our last one. Which medication does the nurse anticipate administering to a patient with venereal warts? For the venereal warts, it is B, podophyllum rosin. It is indicated mainly for venereal warts. It's not effective against the common wart. Thank you very much. That's the end of ear, eye, and skin. Make sure to remove or review application of eye and ear drops. Utilize your test prep. Look at how familiar some of these drugs are that we've reviewed. Many of these medications we've seen in different forms. Don't forget, optic means for the eye or ophthalmic. Otic is for the ear. Okay, so we want to review those as well. I appreciate it. Thank you very much.